Anil sir.
Sir, live streaming is sir.
Oh, okay,
లైవ్
sir.
స్ట్రీమ్ ఒక్క నిమిషం సార్, అది వెళ్తుంది, అది స్ట్రీమ్ లోకి వెళ్తుంది సార్. ఇంకా
ఓకే. ఎగ్జాక్ట్ 1 అవరా? లేదు టైం ఏదైనా ఉందా?
మీ 1.5 ఓకే సార్. మీరు 1.5 అన్నారు కదా, 1.5
ఓకే, ఓకే. ఇన్ కేస్ ఎక్కువ అయిందంటే మాత్రం కొంచెం ఇన్ఫార్మ్ చేయండి.
ఓకే అండి. ఓకే. రామ్మోహన్ సార్, మీరు లైవ్ స్ట్రీమింగ్ చేసే
ఓకే సార్, స్ట్రీమింగ్ స్టార్ట్ అయింది.
ఓకే
చేసాను సార్, ఇప్పుడేం చూడండి సార్, యూట్యూబ్ మీకు కనిపిస్తుంది.
ఓకే సార్. Good morning, one and all. So today we are starting the first webinar 2026 and from Department of Pharmacy Practice. I'm very happy to invite our guest talk from Ganesh Pandyan Balasubramanian today. So welcome, sir. So Ganesh Pandyan Balasubramanian, Assistant Professor, Clinical Pharmacy and Pharmacy Practice Unit, Faculty of Pharmacy, AIMS University, Malaysia. So sir has completed his B.Pharm in Charan's College of Pharmacy, Coimbatore, and completed his PG in KMCH, Coimbatore. From 2009, he have been playing several roles. So like a patient counseling pharmacist at Tulsi Pharmacies Private Limited, and worked as assistant professor in Sri Vishnu College of Pharmacy. Then has moved to senior lecturer and assistant professor at AIMS University, Malaysia, and presently working, and has several research interests like geriatric pharmacotherapy, public health, metabolic syndrome, and so on. And also lifetime member in Malaysian Society of Geriatric Medicine, Federation of Clinical Pharmacists of India, Clinical Epidemiological Network, and several other organizations. Sir has more than 30 publications to his credit, and also has won several awards at research publication presentations. And he also has involved in several public pharmacy practice activities. And I would say the starting of pharmacy practice department in our college have a pivotal role in establishing pharmacy practice department in our college also. So with this brief introduction, so over to you, Ganesh sir.
Thank you so much, Anil sir. It is always a pleasure for me, whenever I have the memories of the Vishnu College. So, as you mentioned, like my career, especially the academic career, started from Sri Vishnu College of Pharmacy, Bhimavaram, and then only I moved on to Malaysia. So I will be Sri Vishnu College of Pharmacy. I hold a special place for me. It is pleasure for me to again to interact and to come in contact with the Vishnu College, and especially with Anil sir. Thank you so much, Anil sir, for contacting me. And also, I would like to thank my the management of Vishnu College for giving me a chance. So maybe with that, I would like to start my presentation. So, uh, okay, sir, can you allow me to share my screen, sir?
You can share.
Yeah. Sir, still the host isn't allowing I need permission.
Try once, sir. Try once now, sir.
Okay. Yeah, thank you. So now I can share my screen. So
Okay, sir.
Sir, I have shared my screen, so hope is it visible to everyone, and also like the screen is moving.
Yes, sir. The
Yeah,
screen is
screen is
visible,
visible.
sir.
Okay. Thank you so much. So now in India, it is morning. Yeah, very good and pleasant morning for everyone. So I am Ganesh Pandyan Balasubramaniam, and thank you, Anil Kumar sir, Dr. Anil Kumar sir, for giving me a brief introduction about me, and also like for making me to deliver the session for today. So my topic of concern for this session is going to be the geriatric care assessment, where to be more specific with the pharmacist's perspective. So before I go with this, like usually in my slides, I just mention only the the university or the institution where I am being part of, like the AIMS University, Malaysia. But being like, I think I can proudly I can say like I'm also been a part of Sri Vishnu College of Pharmacy. So I have included both the pictures, and also like my life or my academic journey also have begin from Vishnu to AIMS University. So I think with that, I want to. This is our beautiful campus. So this is also like a very beautiful campus, like where I enjoyed my most of the time, right? Okay. So today for my session, like during in my session, the learning outcomes is going to be I have included a few learning outcomes. By the end of the session, the participants will be able to understand the need for the geriatric care, explain what is geriatric syndrome, outline the essential screening tool for geriatric patients, which will be crucial for the geriatric care provision, and to detect the early and intervene significantly to improve the outcomes of the quality of life, and to comprehend the roles of the pharmacist in handling the older adults. So altogether, just I want to put in a nutshell, like in geriatric care, like now as a pharmacist, we do provide a pharmaceutical care, and also as a clinical pharmacist, we will be having a more impact on the public. Like we will be having an opportunity to serve for the well-being for every human individual in order to achieve a pharmaceutical care, right? The principle according to the principle, and likewise in that where there are certain exclusivities where there before, and that includes the geriatric population also among them, right? So even the pharmacotherapy or even any medications which have um, been in the market, like it was not so particular for the geriatric. Even for the pediatric population, there was pediatric specific doses, but for geriatric, like it was no special. Like it is very general. Like whatever have been applied for the normal adult, it can be the same for geriatric. But sometimes like that is or that cannot be possible, or that cannot be acceptable for the geriatric care. So which means a geriatric population or very vulnerable population, like by now there are some awareness for the geriatric among about the geriatric population, and also like the healthcare to be provided for the geriatric specifically. So in that like we cannot extrapolate, or we cannot just include whatever we have been decided for the adult population to the geriatric population, because like they are completely different. So which means like, as you all know, and as every one of us know, like by now, their their physiology is not the same. Their pharmacokinetics is not the same. Pharmacodynamics is not the same. Every drug which is going to act in an adult in a one particular way, it is going to be completely different for the geriatric population. Which means they got other comorbidities, they got other problems, right? It is very complex, or it is very confusing kind of therapy which will be which will be provided for them. And also like with their body condition, and also the medications what we will be giving for the geriatric population, this also is going to be completely not so safe, like for what we will be providing for for an adult population, or even to some extent for the pediatric population. Where today in my lecture, like I'm not going to discuss about the drug therapy, and I'm not going to discuss about the drug related problems and those kind of things. But while we are providing a treatment for a geriatric population, when a treatment is being provided for a geriatric population, so in addition to this therapy, what is being given, in addition to the change in the physiology and change in the pharmacokinetics and also in the pharmacodynamics, like there are other contributing factors which will be playing a role in deciding the outcome of the therapy which is being given for the geriatric population. Where or it not necessarily directly related to the treatment, or it's not directly related to the healthcare therapy which is being provided for the geriatric population, non-healthcare related, but still that will be contributing more for deciding treatment outcome for a geriatric population, right? So, and why I want to even specify or even to fine tune this topic into like a pharmacist perspective is this pharmacist like being the first person or first line person in communicating with any individuals, like in the public, like we will be the first person to be approached by any individuals, right? So actually we are the frontliners, even whether they are any pandemic or non-pandemic, like whatever it is, like we are the frontliners for the healthcare team, I can probably say. So being the first person or first point of contact for a public, like we will be seeing or we will be accessing, or the geriatric population will be accessing to us, right? Like any other population, where we can take care or we can note certain parameters for the geriatric population so that it can be decided whether the treatment, to make the treatment in a very better way. So the pharmacist, like every farm, irrespective of being in any department or any specializations, like as long as we are being in contact with a geriatric population or in a patient care, like we need to be aware about certain parameters where that geriatric individuals will be facing on, so that it can be taken care of, so that their treatment outcome can be in a very better way, right? So that is why like my treatment or my topic today is going to be in the pharmacist perspective area, and where I'm going to look into, or I'm going to discuss about this outcomes, the learning outcomes, and you will be able to achieve this learning outcomes. And in additionally, I have included some of my research findings also for this study, for this presentation. Okay, so as we all know, any age or the age to be to consider any individual as a geriatric population is like some they consider like 60, and some nations they follow 65, right? It is differing from 60 to 65, but most of the places, like as per the WHO also, like you can see, like anyone more than 60 years and above are being considered as a geriatric population. And in this aging parameter, like we need to consider two important aspects. Like one is the life expectancy at birth and life expectancy for the geriatric individual, where if you can see this graph, like which is from the organizations, where the life expectancy for any countries, like you can see, like India comes into this category, where 60 to 70, like any individuals who who born in India will be having an average life expectancy of 67.3, right? So which means like the life expectancy have been reduced to some extent, and some countries like it is being increased also, where overall, like for a geriatric individual, like if you look into the life expectancy for the geriatrics, like how long they can live more, also it is a parameter where we need to consider, right? So according to the data.org, where you can see like the different continents, like what is the life expectancy, where for it is differing for one particular continent to another particular continent. It may be due to their lifestyle, it may be due to their practices and the healthy practices that they adopt during their younger adulthood, or pre-geriatric phase, like so that will decide on their lifetime expectancy also. So every nations are being categorized or being considered as a geriatric or a aging nation, like which means like the majority of the population living in that country is above 60, which means like every nation. So that's why the name, the label as a aging nation is being labeled for any country, right? So majority of the country, they are reaching to a level, or they are reaching to a category of aging nation. So which means the geriatric care which is being provided, the pharmaceutical care which is being provided generally, it have to be more specific to the geriatric population also, right? So by the way, like we also we from India also, like it is we are aging nation, so the life expectancy is being increasing, right? So it will be increasing like more major, and also the percentage of the people or the population who will be under the geriatric category. So they are also being increased, which means like we need more specific approach for providing any pharmaceutical care, and no longer we can ignore we can be ignoring the geriatric population, right? So here, this is the statistics says like every country or every nation is being categorized as aging nation. Majorly now, by now, like every country have attained that status. So understanding this geriatric, the aging, where aging, like us, anyone who can say or anyone who can define, like aging is a process which is inevitable. You cannot avoid that one. It is irreversible, like it cannot be reversed again also. Like maybe it physically there may be some methods, or they claim like we may look younger, but our age is increasing day by day, hour by hour, and also the minute by minute, right? So every minute we are aging. So as in the early phases, like when we are aging, it is not going to do much changes on our body or changes on our physiology or even in any other parameters. But once we reach, or once any individual who reach the geriatric or the geriatric age group of 60 and above, like even though they are not having any disease, they don't have any illness, but still the body function, if you say like if it is going to be same like their adulthood, means like definitely no. Even though irrespective they are not having any disease, like even though diabetes and not hypertension also, like they will be having their bodily functions decreased, right? So this is for a normal adult who have been aged to a geriatric category. But consider like the adult where they will be having a poor lifestyle, means like then it is going to be very difficult. The point over here is like the aging is going to decline our organ function, which means like our organ functions is declined, and also like it have to be taken consider for any treatment that we have been providing for. So initial changes from for this aging, it will not be very early, and also you will not be seeing, or we will not be observing this changes immediately. But the baseline function, what our body is capable to do, our quality of life, it will be decreased by that time, right? So the first manifestation for a geriatric population would be in reducing the capacity to maintain any homeostasis. Like as we all know, like homeostasis is a process where we our body try to maintain or to put it back to the normal. But at the age of 60 and above, like even that normal process of our human body, like have been reduced. So which means like it will having the difficulty where this, I don't mention like it have to happen only when there is some illness or so there is some disease. No, it will occur normally. So which means like we need to know like every geriatric population we have to see or we have to approach differently. I'm not saying like geriatric patient, it is the geriatric population, which means like not every geriatric individual will be a patient, right? So there are many healthy individuals which falls under the category of the geriatric age group, right? So there we need to know about the weakest link system. Like the weakest link system is where the organs, as I have mentioned before, like the organ function will be decreased for the geriatric population. So the very vulnerable organs or the organ system which will be decreasing its function very commonly are the three, which is cardiovascular, renal, and the central nervous system, right? Any little change or any minor impact on this system, it is going to cause harm, and it is going to be a cascade of events which will be leading to the medication administrations, and also like that is going to lead, or that is going to in an very pathetic stage where like they're sometimes in their reduced lifetime also, right? Even though like where they might have been expected to live around 80 or 85 without any conditions by now. But any impact or any influence on this weakest link system, like even a drug which is being administered, which is being renally excreted, and it causes a nephrotoxicity, right? Where in a normal adult it can be reversible, but it causes nephrotoxicity in the geriatric population. Like it cannot be irreversible, and also like the complications that we are, or the consequences that we are going to face with this condition is going to be very troublesome, right? So it have to be taken care of, and also like these three systems are the most vulnerable, so that's why it is known as the weakest link system, right? So any impact on this have to be avoided, right? So yeah, the another terminology where with the geriatric pharmacotherapy that we need to know is the geriatric giants, which includes a a syndrome of other diseases, where the geriatric giant, it includes immobility, which is also known as the instability. Sorry, it's not instability, the incontinence, the intellectual impairment, and the iatrogenicity, right? So the immobility is a condition where they cannot move around, like their mobilization or their able to move around, that category have been reduced, right? So their ability to move around will be reduced, right? So if this ability to move around, it's not going to one place to another place, right? So it is not outside. Even in their home, like they will be having a difficulty to move around, right? From their bedroom, from their bed to the washroom also, like it is not going to be the same for a geriatric individual. Some patients, some individuals, they may be completely bedridden, so they will be completely immobile, right? So, and the instability, also known as the falls or the gait impairment, where we walk normally, but they for them it is not going to be the same, right? So they not be able to hold their urine, right? So we can hold to our washrooms, like we can hold it, but for them it is not going to be like a normal adult, right? So the incontinence and the impaired cognition, right? So their cognitive ability will be decreased to some extent, right? So this geriatric giants will be deciding or will be having a significant impact on their quality of life of the geriatric individual, and also their living ability, right? So we will be seeing one after another later in the following slides. So with this is the geriatric giants that we have to be aware about. So the first one, in geriatric, considering the geriatric giants, like my assessment or my session for today is going to focus on this parameters or this conditions, like deciding on the functional impairment, assessing the cognition or cognitive behavior of the geriatric individuals, gait and the instability, elder abuse, and the medical and medication history, right? So this comes under this geriatric giant directly. If you look into the functional impairment, cognition, or the gait impairment, it's directly included in the geriatric giant. But if you see like the elder abuse or the medical and medication history, from where it is, it will be considered in the iatrogenicity. Iatrogenicity is any harm which is being caused by the treatment, by the care what we are being provided, right? So this comes under the iatrogenicity. And also in addition to that, I have another condition also. So I will take you through during my presentation. So first one that we will be seeing is about the functional status, where functional status, where to decide on any individual, whether they can live alone or whether they need a real support, for especially for an adult, is not really a bothersome, but for a geriatric individual, it is really a bothersome, right? So in order to assess their functional status, we need to know like what are the ability that the individual is having, so that by deciding that we can provide a treatment which is more suitable for them, and also like we can make decisions to for their livelihood, and also for them to stay, right? So this functional status or the functional impairment is defined as the difficulty in performing or requiring the assistance of another person to perform one or more of the following activities of the daily living, where out of this we will be performing in a normal day-to-day activity, we will be performing certain activities, right? So which is really important and which is like less important, and some activities like not at all important, right? So to lead our life. So to assess the functional status of any individuals, this functional status is being categorized into ADL and IADL, which is nothing but the activities of daily living and the instrumental activities of daily living. So this, based on this, the ability to perform this activities, so it decides whether any individual is able to live alone or whether they can live independently or not, right? So here I have included some of the activities like bathing, dressing, eating, and eating under the activities of daily living, and preparing the meals, shopping, managing their medications, and the housekeeping. Like it is the instrumental activities of the daily living. So out of this two, if you look into this, like which is more important, right? So everything activities like it looks important for us, for us, but for a geriatric individual, if you want to categorize like, or if you want to prioritize like which is more important, whether it is the activities of daily living or the instrumental activities of the daily living, so it is, you can refer to the definition again, like any functional impairment is defined as the difficulty in performing or requiring the assistance of another person to perform one or more of the following activities of daily living, which means bathing, dressing, eating, right? So it is really important compared to the meal preparation, shopping, and housekeeping and managing the medications. I'm not saying like taking the medications, the managing the medications. Why? Because is this we need to do regularly, we need to perform regularly, and also like if we don't do this, it directly affects the quality of life or living quality for any individuals. So if any instrumental activities of daily living are not being performed by the geriatric individual, this can be substituted, or this can be being taken care by any other member, right? It's not necessarily like the geriatric individual have to prepare his own meal to eat. If he cannot prepare the meal, he can depend on any of the other members, right? I'm not speaking about the family members, right? So if the family members also like, they can prepare for them. If there is the condition where the geriatric individuals are living alone, where they don't have the support from the family and they are the persons who are living alone, so they want to have their meal every time, right? So every meal they need to have. So if they cannot prepare by their meal, so it's not like they need to go for a starving. They can go for an other supplemental services, like they can ask anyone to prepare for them, or they can get the food from other places, and also like they can get it, they can visit and have it, and also like they can have some supplemental services, like the agencies or the services or from any organizations, they prepare the meal and then they will be delivering. And likewise for shopping, it's not necessarily like this activity have to be performed by the geriatric individual for sure. If it cannot be performed, it's like it can be performed by the any other member also, right? So that's why like this instrumental activities of the daily living can be this is also is required, but not so important than the activities of the daily living, which means bathing. If he cannot bath by himself, they have to be kept they have to be they will be kept dirty throughout the day, right? So if you can notice like the geriatric individuals, and also if they are not being taken care of, one thing that you will immediately notice is like they will be dirty, right? They cannot keep up themselves, and also like they cannot maintain their proper hygiene, so they will be dirty, right? So this is really important, right? So dressing, they have to do the dressing, eating, so it have to be performed, right? So here now the point to be taken care, like to whether they can live individually or whether they can live independently or not. So whether this can be decided whether if they cannot perform any one of these activities of the daily living. Okay, so because of their age, where the ADLs are the essential elements of the self-care, where it will be inability to independently perform even one or more activity will indicate a need for a supportive services, right? So IADLs are associated with the independent living in the community and provide a basis for considering the type of services and necessary in maintaining their independence, which means they have to be decide on whether they have to be placed under a supervision of other member like a nurse to take care of them, or if not means like to place them in the nursing homes also, right? So here I have included some other activities also, like which will be categorized into the activities of the daily living and also the instrumental activities of the daily living. So bathing, toileting, dressing, eating, and continence, right? So this activities of daily living have to be performed for sure. If they cannot perform by themselves, it cannot, some other cannot perform by it cannot be performed by the other members, right? Other members can help us, can assist us to perform these activities, which is really so important. But this instrumental activities of daily living, it's not so important, right? So not so important, I mean to say like not so important than this activities of daily living. So here there might be a question like what is the transferring is? It is the ability to move or ability for us to move from one place to another place. It's not like moving from one city to another city or from home to a shopping mall or like that. It is like inside the home, like whether they can move around from the bed to the toilet, bed to the hall, or whether they are having their ability to move around, right? Because if they are having a difficulty in transferring themselves from one place to another place, then definitely they may not be having access to most of the services or most of the important information or most of important activities that need to keep them alive, right? So their medications, it may not be it may not be administered, they cannot be taking their medications on time, right? So they need to really depend if they cannot perform, right? So to look into this functional ability, so what we need to do, like if any geriatric individual cannot perform even one of the activity from here, definitely they need a supportive services, right? So they have to take care of them. Okay, so the clinical implications of the activities of daily living. So the ADL impairment will strongly predict the hospital outcomes, the functional decline, and the extended stay or the duration of the stay in the hospital, and also like the mortality, and also it will be surpassing the diagnosis for the admission. So, which means it is also a deciding factor in getting better, right? Even a treatment is being provided, but if they are unable to do the ADL by themselves, then definitely it is going to risk the treatment outcome or risk with the treatment what we have been providing for, right? So this straight away, like they can be placed under a direct supervision either by their family member or either by appointed nurses or appointed caretaker, or if not means like if it is not affordable means like they can be placed at nursing homes, right? So maybe there may be back in our country, like we will be having an opinion whether sending our old age people or old age people to a nursing home is not so good. But frankly, like keeping at home, they cannot do their activities themselves and they suffer a lot, right? So instead of that, keep them at the nursing home. It is better. I'm not judging any individuals, right? If they can be taken care by their family members, definitely the family members have to take care. But if there is no any, if there is no much possibility on that means like, then this nursing home placement will be more suitable for them, right? So for to keep up their activities of daily living. Okay, so because approximately 25 or to 35% of the older patients will be hospitalized for the acute illness who lose the independence in the activities of the daily living. The complications, the consequences is very much with the ADL impairment. So it is better like to provide them a healthy living with their geriatric conditions, and also like with the geriatric provided the circumstances, like it is better for them to place in the nursing homes. Okay, so here, this functional disability, we have assessed, my research team have assessed the functional disability among the population, the geriatric population in Kedah. Kedah is the state where I'm being placed in. So it is one of the state like in Malaysia. So in this state, we have assessed the functional disability among the geriatric individuals. It's not like the geriatric patients, among the geriatric individuals. Around 42-hour study finding have found like around 42% was estimated to face at least one difficulty with the activities of daily living. Among the study population that we have conducted, around 266 elderly populations participants have been included for the study, and out of this, around 42% have a difficulty in performing one activities of daily living, which means like they have to be provided with the supportive services. Why I'm speaking about this is like the consequences. If they cannot perform these activities of daily living, so what will happen means like even we set them a treatment for for getting better with their condition, like they may not be able to achieve the outcome, right? So it affect their problem. And out of this study population, like 57% have at least one difficulty with the instrumental activities of the daily living, which is it's just okay, right? And out of this instrumental activities of the daily living, like transferring and the transportation was mainly of limited among the geriatric populations, where the transferring is an activity of the daily living and transportation is the instrumental activities of the daily living. Transferring inside the home to move around, transportation from home to other places, from home to hospital, from home to nursing home, right? So the transportation is not going to be that difficult. It can be taken care, but transferring 22% out of this 266 elderly, they have a difficulty, which means like they need to be kept or they need to be really have an assistive services in order to lead their life happily, right? So by the way, like this study was conducted among the general public in the state of Kedah who have been living at home, right? So they are not hospitalized, they were not admitted to any nursing homes, right? So they were living. So which means like around 22 percentage they need or they have a problem in transferring. So which definitely affects with other consequences or other treatment strategies for the geriatric population. So where this as a pharmacist, how we can assess, like you can interact when you are interacting, because like the pharmacist will be the person to interact with the geriatric population, whether they come for the medications or whether they come for any screening or whether they come for any consultation in the community pharmacy or even to your pharmacy location. So you can interact with them and then you can know like what is their ability so that it can be decided. Like it is just nothing. It is just a 2 minutes of interaction, whether they can do it perfectly, they can do it or not cannot do it. So based on that, we can decide and we can recommend on, right? So we cannot enforce or we cannot force them, but we can provide recommendation on, right? So if not to the geriatric individual, maybe to their caretaker who will be it can be their family members also, if anyone, and if there is no any family members also, still we can recommend for the placements in the appropriate services. So the next service or the next parameter that as a pharmacist that we can see is like assessing the cognitive impairment, right? Assessing the cognitive impairment, because the medication taking behavior for the geriatric individual will be majorly influenced by their cognitive ability. The cognitive, if any individual having the cognitive impairment, then definitely it directly affects their medication taking behavior, which directly affects the compliance to the therapy and which will be leading them to a non-compliant and will be completely leaving them to not achieve any therapeutic outcome, right? So if in a hospital, like they can be, even though cognitively impaired or not impaired, like it doesn't matter, the nurses are going to administer the medications for sure, for continuously, whether they are willing or not willing. So it can be administered. But a cognitive impaired patient or impaired individual who are living outside the hospital, they are not hospitalized, they are living normally. So which means like that will be having a major impact on the drug, and also like it will be having we have to be really focused on this, right? So not every geriatric individual not being hospitalized and they are roaming around us, um, we cannot say like they are cognitively good. They may be having a cognitive impairment, so which is also really important. So the clinical implications for the cognitive impairment, we can see like the many elderly patients will be will be seen by the surgical and the medical specialist and the subspecialist, which will be they will be having the cognitive impairment, where most of the time this cognitive impairment is left undiagnosed, right? So the cognitive impairment, you cannot have a picture like how they are being depicted in movies or depicted in a non-professional way, but they looks normal. They will be having their leading their normal day-to-day activities. They will be having their activities of daily living also. It will be good, right? So which don't need for them to be placed in a hospital or anything. But we cannot consider or we cannot judge by looking them that they will not be having any cognitive impairment. So we cannot do it in that aspect, right? So this unrecognized cognitive impairment is a risk factor for a medication on adherence and also for the poor compliance, which will be having the behavioral recommendations and difficulty navigating in the healthcare systems, and also like it will be leading to a caregiver stress. Caregiver stress, it directly plays a major role in the elder abuse. So if the patient is cognitively impaired, like even for a pharmacist, for a doctor, when we give them some instructions, if they are not cognitively good, cognitively healthy, right? So if they are impaired, so the information or the instructions what we will be giving to the patient or to the geriatric individual, they may not perform it or they may not follow it appropriately. So which means like which will be a challenging factor for us to get a treatment outcome as we have decided. And this will definitely leads a stress to the caregiver, not necessarily to a healthcare team member. Maybe it may be to their family member also, because every individuals will be taken care by the family members. Most of the geriatric individuals are being taken care by their family members, right? They either by their son or daughter, like their close family members, right? So if they, due to this cognitive impairment, like they may be having difficulty in following the instructions, and also like they don't take the medications, and maybe the other risk factors also will be giving the caregiver stress, right? So which leads to further consequences, which will be having impact or which will be having a burden on the caregiver also. So the most common causes of the cognitive impairment in elderly patients are the dementia, depression, or the delirium. And the undetected cognitive impairment can lead to the significant health complications and also to the caregiver's burden, right? So here, how we can assess the caregiver's burden, right? Maybe this is like the primary assessment, right? The primary assessment, like it's not the confirmatory assessment. The primary assessment for any geriatric individual who is visiting your pharmacy, like how you can assess whether they are cognitively good or not. So one of the tests is, there are many tests available. Like one of the commonly used tests is the mini cog test, which occurs no any equipments, which requires no any complicated or sophisticated what to say, like sophisticated uh, techniques, where this we can do by how to perform like this mini cog assessment. It will be having two parts. Like one is identifying their ability, and also like the other one is like you will be assessing their recall ability. So this test have been performed by initially mentioning like by performing the 3-item recall method, and then followed by the clock draw test, where the 3-item recall method is like when the geriatric individual is visiting you, they will be visiting your pharmacy. So what you can do is like make them comfortable, like they sit in front of you, just state or give them three names, right? It is not any the common objects like fan, car, then any three names, which should not be having a relation to each other, obvious relation to each other, just like fan, AC, and air coolers. This is having a little relation. Car, bus, and train, it is related, but maybe you can give three names, a layman's words, and also like it should not be obviously related to each other. So that is, you can give the three name, and after you give the three name, so you ask them to perform a clock draw test. Clock draw test, which is also known as the CDT, where in performing the CDT, what you will do is like you ask them to draw a clock, and also ask them to write the number, right? So how a clock looks like. It's not a digital clock, it is an analog clock. Like it have to the individual have to uh, write the number reflecting the clock, and you can say a particular time, right? So you can say like to draw them for 11:20, or say a particular time, right? So this is clock draw test is being performed as a distractor, right? So this assess the executive function and also their visual spatial skills and also their abstract thinking. Where after this clock draw test have been done, you ask the patient to recall the three names that you have given before, right? So you should not inform here in the step one that you will be asked it again, but you can give the three names. Then after that, you perform the CDT. And after you perform the CDT, now in step three, you ask the individual to recall the three names, right? So what the three names that you have given, so you ask them to repeat the three names. And based on the number of names that the geriatric individual will be repeating, so it will be having their we can interpret based on their finding, right? So after the minicog is being performed, like any score which for each word recalled, you can give 1 point, right? So totally 3 points you are going to perform, and the clock draw test is assessed for the correct number and placement, right? So when you are stating a particular time, so whether they have wrote correctly or not, right? So you can check whether the clock draw test is normal or not normal. So based on this, when the patient or the individual is not able to recall any one name also, like they cannot recall even one name, then definitely the marks is going to be 0 points, because like for each word recalled, there is going to be 1 point, right? So for they are unable to recall any word, so it is going to be 0 points, and they are this irregardless of the CDT, the clock draw test. If they cannot recall any one name, it clearly indicates the dementia. They can even if the CDT is normal, they have drawn the clock normally, and also they have given their timing also, what how you have instructed. So they have performed that. The CDT is normal, but they couldn't recall any one name, which means like they clearly comes under the category of the dementia. And next, if they were able to recall one or two words, they are going to get 1 or 2 points, but the CDT is not normal. You ask them to draw 1120, but they have drawn otherwise, right? So it is not correct. Like it is considered like the abnormal CDT. So in that case, it also suggests the dementia, where a detailed neurological and cognitive workup should be pursued, which means like they need to be referred to the concerned physician, so or the psychologist or psychiatrist, not the psychiatrist, concerned a physician, so they can assess on their cognitive impairment, right? So this don't need a psychiatric assessment. So if the recall test can provide 1 or 2 points, like they are able to recall one or two words, which will be giving like 1 or 2 points, and their CDT is also normal. So which means like there is no dementia. Here you need to be very clear, like if they can score 1 or 2 points, but their CDT is abnormal, then it is dementia. But if normal CDT with 1 or 2 points, it indicates the absence of dementia. So if they were able to perform or they were able to recall all the three words, they indicates or that indicates absence of dementia regardless of the CDT, even if they have drawn the clock or they have performed the CDT wrongly also, like it can be considered like the dementia is absent for the individual. So this is by doing this one, we can assess whether the the individual is cognitively impaired or not. Okay. So for your information, these are some of the tests where you can see like the CDT, only the CDT, whether if you look into this, which one is normal or not normal, means like if you need to know whether this is normal, this is not normal, this is not normal, this is normal, because like you cannot exactly look like an exact clock, but their numbering is correct, like 12, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, right? So the numbering is correct. And also like based on the time that you have given, like this can be considered normal, abnormal, this also normal, this abnormal. They were able to draw the clock face, but they cannot draw the time, abnormal. This is lack of clear instruction, like you could have asked them to write the number so that it can be made clear. But if it is if the number have been, if the time have been clearly depicted, then maybe it may be considered normal. This is completely abnormal. Okay, so this is for the mini cog assessment. So in addition to the mini-cog assessment, there are other methods to check on the cognitive impairment, which includes like the MMSE, Mini Mental State Examination, Montreal Cognitive Assessment, Clock Draw Test alone, and also like the AMTS, Abbreviated Mental Test Score, right? So this scores are the commonly available one. And also like I prefer to go with the mini-cog assessment. Like usually if you can see, for quick and primary screening, mini-cog assessment is the better choice. And for traditional standard screening, MMSE, where it takes some time, where it will be difficult for us to assess uh, rapidly and also like in the initial phase. And also for detecting the mild cognitive impairment, you can go with this one, right? So out of this, the mini-cog having um, easy word, like it can be performed in 2 to 3 minutes time. So I usually prefer go with the mini cog assessment. Okay, so the next condition that you are going to look into or you are going to assess as a pharmacist is assessing the depression among the geriatric, like depression, like it can happen not necessarily because of their disease state, even because of their age, because of their family, or even they think about their normal life when they were been having before the geriatric phase. It causes depression. Like now, commonly, the depression is very commonly prevailing among every category, our every age group, and most commonly prevailing among the geriatric population also. Where around 20 to 40 percentage of the geriatric population is prevailing with the depression, and in the older patients were affecting the 20 to 40 percentage, where it significantly impacts the quality of life and also the treatment adherence. Like by the way, like whatever the treatment we have been setting for, like if they decide, like by most of the time, like if you look or if you check on the geriatric population, what they say is like they don't want to follow, or they don't want to what to say, like compliant to the treatment, because they clearly state like already I am at the end of my life, so I don't want to live any further, so I will not be taking any medications, I don't want to follow the treatment. So this is maybe because of the depression, right? So which will be further complicating our task as a pharmacist in providing a geriatric care for the individuals. So here what will happen is um what to say, like this depression also can be avoided if we can detect early. And also this the categories of the depression, like the major and the minor depressions, are treatable in the elderly patients also, same like the other age group, right? So it's not like the depression occur in the geriatric patients, like it will be difficult to treat or it is difficult to cure. It is also equally treatable and curable like the other age group patients, other age group individuals. So it is a one good information so that we can approach on the depression. So that means, like as a pharmacist, when they are coming in, we are coming in contact with the geriatric individuals, we need to know whether we need to assess whether they are having a depression or not. So that based on that, so maybe we can refer them appropriately, because like we cannot provide the treatment, we can refer them to the concerned physician only. Okay, so the depression lowers the patient's quality of life and also contributes to the poor adherence, and also it significantly reduces the patient's engagement in their own care. Because of this, even they can be better with their treatment. So if they have depression, like they may not be following or they may not be complying to the treatment which is being provided. So there are some medical disorders that can mimic the symptoms of the depression, which something like the apathetic hypothyroidism, where this also have to be clearly diagnosed. So other medical conditions such as the malignancy and the Parkinson's disease and the dementia also will resemble like the depression, but we need to categorize accordingly. We need to recognize and treat the depressions in the older adults, which can improve their outcomes. Okay, so in order to screen for the depression, I have chosen two tools. The first one is the GDS-15, which is also known as the Geriatric Depression Scale 15, which represent like there will be 15 questions will be there. It is a questionnaire based assessment tool. So it will be having a 15-item questionnaire, which will be adaptable for the written completion and also for the interview format. Either you can do it as a interviewing method, like you can interact during your counseling. You can during the patient counseling, you can interact with them and you can ask them the question and they can answer for. Or if not, means like you can provide them the questionnaire if they are able to attend it by themselves. Means like you can self-administer this questionnaire to the geriatric individual, right? Basically, it will be having a 15-item questionnaire. So there will be feasible for pre and post visit administration in high risk patients, where it is easy for implementing for assessing this geriatric depression scale. Where the interpretation out of this 15-item questionnaire, like if 1 point is given for 15 questions, there will be a total of 15 points, where if any individual scoring 0 to 4 points, it generally implies that their mood appears to be fine, right? So there are minimal concerns with the depression. And also if the points is 5 to 8, that indicates the mild to moderate indication of the depression, and also it will be contributing to we need to refer them to the physician. And if a score of 9 and more, it demonstrates the greater depression. So which means like based on that the interpretation tool, we can see and you can know like which is if they are replying for everything for more, uh, it is going to indicate like they're having more depression, right? So up to 4, it is considered like their mood is appearing normal. Okay, so if you think like in implementing this 15 questions for an individual, it will take some time, right? So maybe if you ask me like, is there any other tool which can be used immediately, right? Or we can implement for the geriatric patients. There is another tool which is also known as the patient health questionnaire 2, uh, which is shortly known as the PHQ2, or also like 2 question screener method. Like that is the easy and short way to check or assess the depression among the geriatric individuals. Where this PHQ2 inquires about the frequency of the depression mood and also the anhedonia over the past 2 weeks, right? So for the past two weeks, like this implementation, like when we are assessing the depression, we cannot consider the values what we have performed a few months back. Like you cannot say like I have assessed this individual on January, so he was normal that time, and also like consider he will be normal now also. Definitely no. This assessment have to be done timely, which means for a geriatric depression, so you can if you suspect that there is any chance of the geriatric depression, so you need to assess for this individual. And this is the PHQ2 is a very short questionnaire. It will be having only 2 questions, right? So 2 questions, it will be assessed, and based on that, you can decide whether they need a referral or not. So this is the questionnaire exactly extracted from from their official website. Over the last 2 weeks, how often have you been bothered by the following problems? Where the options given are here, and based on this, the scoring also have been given. Where little interest or pleasure in doing things, feeling down, depressed, or hopeless. If the individual select like they are having little interest or pleasure in doing things, where they are going to choose their answer, right? So based on this, the scoring will be given. And also like for the second question, like are they feeling down, depressed, or hopeless? Based on that, they are going to select their scores, right? So for the interpretation, the score will be ranging from 0 to 6, because the top score, the higher ceiling point of the value is +3, which means like for 2 questions, it is going to be 6. And if the lowest value is 0, so the score will be ranging from 0 to 6, where the author identify a score of 3 as the optimal cut point when using the PHQ2 to screen the depression. Where any score of 3 or greater, major depressive disorder is likely, and patient which will be having, if they answer to any one question also, like it can indicate like they are having some depressions, right? But if they answer if they select nearly every day for both the answers, it is going to be like 3 and above. So, and also like likewise, like if the score is 3 and above, the depression is major. So which means like immediate attention and immediate treatment for the depression is needed. So by doing this, we can avoid the depression also, right? So The other tools which are available for the for assessing the geriatric depression, it is geriatric GDS 15, and the PHQ2 is the one I have described you, which will be easy for the implementation. In addition to this two, there is a PHQ 9, CSDT, right? So and also the other scale, right? So they are having their own key features and also like their feasibility in implementing in our setting, right? So this I have made it into a chat, and also like you can compare it between this, and maybe if any other scale is being more suitable for you, maybe you can select for that, right? So for community pharmacy setting, like in order to assess in a community pharmacy in a very rapid phase, like it can be PHQ2 is going to be a very easy administration questionnaire, right? So GDS 15 is most preferred from the among every practitioner. So coming to my research, like for the depression, I have checked on the my research team have checked on the prevalence of the depression among the geriatric population in the northern region of Malaysia, where northern region of Malaysia, it includes four states. Four states will be there. So out of that, our finding, like there was a majority of the geriatrics in the northern region who faced depression among the geriatric population. I conducted the study among the geriatric population, like the study finding have been found to be like a majority of the geriatric population have are facing the geriatric depression, right? Out of this, when we further inquire on that, the reason for this is the level of education and also the duration of the sleep. Like the sleep duration was less or little, that also have contributed to the geriatric depression, right? So it may be have to be taken care, right? So in order to assess that, I conducted another study where to assess the sleep quality among the geriatric populations who are residing in the northern region of Malaysia. Our study finding have shown an association between the age, medical conditions, and the coffee consumptions with the PSQI score. Like it is one of another assessment tool to check on their sleep quality index. Like it is the Pittsburgh Sleep Quality Index. So we have found our study results have shown like more than half of the respondents have a poor sleep quality, which means they are not having any depression. But currently, when we assessed among them, so they were having poor sleep quality, which is around more than 50 percentage, which means like this can be leading to the depression also, right? Out of 392, more than 50 percentage have been having sleep disturbances, which will directly relate or which will directly lead to the depression also. So which can be avoided, right? So the next one that I'm going to discuss is the falls or the gait instability. So here, the falls or the gait instability is the leading cause of the injury-related death among the geriatric individuals, and also it is a threat for older adult, right? So even though we have, I mentioned like the geriatric individual who is not having any disease and who don't have any comorbidities, and they fall down, right? Not someone push, but normally like due to their aging factors, like they may be falling down. So if they fall down, it may leads to another medical condition which needs medical treatment and which will be leading to the mortality also. So even though they don't had any comorbid conditions, no any other medical conditions, but a simple fall can lead to the death or mortality of the geriatric individual, right? So among the geriatric individuals, if you can notice also like their posture is not going to be the same, and also like their walking pattern is not going to be the same, right? So they will be little easily they will be easily falling down, right? So once they fall down, that fear alone will be causing them to walk independently, like they will be having a fear all the time. Okay, so and also most of the geriatric cases, like once they fall down, so it is going to be a repeated occurrences, right? So based on their bodily function and also like the based on our body, our physiology, for every fall, there are going to be injuries, there are going to be wounds, fractures, and which will be complicating the treatment and also like the other medical conditions that they are being treated with. Okay, so in order to know whether they are stable or unstable, we can implement a test known as the tuck test, which is known as timed up and go test, right? So in this test, you just need a chair And also you need a measuring tape where to calculate like a distance of 3 meter or the 10 feet, right? So here, step one, you ask the individual to rise from the chair. Okay. Step two, you ask them to walk until the 3 meter or 10 feet distance, and they take step three, they take a turn, and step four, they return to the chair, they turn back and sit down, right? So this is the test. Is this a test? If you ask me, is this a test? It is a test, right? So you are asking an individual to get up from their chair and to cross a particular distance, and then to go back to their chair and to be seated. This, by doing this, you can assess whether they are prone to the gait instability or not. I'll show how, like when we are interpreting this, by doing this test, if the whole process, like the whole process, the entire process, if they can do it less than 10 seconds, within 10 seconds, they are at a low risk of falling. If they take more than 20 seconds, they are at a higher risk of falling. Okay, so if anyone falls under this between 10 to 20, which means like they are still under a risk of the gait instability. So which means like further assessments is required for them, right? So for performing this test, you need to use a standard armchair only. It's not the rotating chair or the rolling chairs cannot be used, and also like the chairs with the wheel cannot be used, right? Because it may lead them to fall down, right? So it have to be standard armchair, and that it should be placed 10 feet away from the distance. And also like the patient should wear their normal on the regular footwear, what they usually they wear regularly. And also they can have their customary walking aids if they can hold their walking aids like the walking stick or any other things that can be used. And no physical assistance should be provided during the test. And also like you allow one practice, like you can provide one trial for them, right? So initially to familiarize themselves, in to know how to do the test, right? So for that you can allow. And once during the test, if they can perform within the 10 seconds, it is better, they are not having any risk. But if more than 20 seconds, definitely they have. And if it is between 10 to 20, it is then they are at a moderate risk, right? So but still a further assessment is required. Okay, now in your pharmacy setting, you are observing this, whether you need to be worried or you need to be concerned about this or not. If I ask you this question, any responses? Broken glasses, some bruises, or some injuries? Feeling sad, depressed, frightened, not attentive, and also like some injuries, and also like they do not wish to talk to you. If you are observing any of this, definitely you should be considering, you should know like that the victim may be undergoing, or they may be a victim of elder abuse, right? Elder abuse is a condition which is being a action or a condition which causes or which is being caused by any individual who will be playing a role of a healthcare or caregiver. Okay, not necessarily, you cannot say like family members they do not abuse and non-family members they abuse. It is not specific to any category of the members. They can, irrespective of any age group or any category, this elder abuse is very common, right? It can be provided like the doctors, the physicians, the healthcare members, the nurses, and most importantly, the elder abuse is occurring at family, at home also. Okay, so here, this abuse can be intentional or unintentional, but still abuse is an abuse, right? So same like the other conditions, this elder abuse is also very poorly reported, like because like of the familial reputations of the fear of retaliation or whatever it could be, like they will be having a difficulty in reporting, right? And maybe sometimes like they will be having a difficulty in assessing a pharmacist also, like they will not be allowed to go out of the home suspecting that they may be informing that they have been undergoing an abuse, right? So there may be many reasons it may leads to the poor reporting of the abuse, right? So there are different types of the abuse, like psychological, physical, financial, and also like sexual abuse, and also the neglect. Like neglect is self-deprivation, like they don't take care of themselves, right? So this are the types of the abuses. And here you can see there are some symptoms where we need to look for, right? Especially like if they are bullying, shouting, blaming, or intimidations. It refers to the physical, psychological abuse, where, as a pharmacist, maybe you can look for the signs of the fear, helplessness, or the emotional liability. And for physical abuse, you can look for any unexplained injuries or even the broken glasses. Also, like if the glasses have fallen down and if it have broken down, it's okay. But what if the fall was due to some other condition? If the fall was being attacked or being abused by by the caregiver, right? So it can be anything. Financial, using their properties and their financial resources to avoid any their livelihood. Sexual abuse and the neglect, I think those are all self-explanatory, right? So in order to identify whether that individual is undergoing an abuse or not, so maybe we can initiate a dialogue or we need to conduct a patient counseling methods. Like you can ask certain questions which will be helping you to detect or to identify whether that person have been subject to the abuse or not, right? So these are the questions that we may be asking for. Okay, so while we are communicating with that geriatric individuals, especially when we are suspecting that that individual have been undergone or undergoing or suspecting to be abused, so you have to conduct an interview or the counseling separately for that individual alone, right? So based on that, we can identify, and after that, we cannot intervene on this, and we need to report it to the concerned authorities, right? So we cannot have say in this, right? So we have to be reported to the concerned authorities. Wait, the patient responses, what we can identify for identifying this elder abuses, like they will be delayed in the treatment, right? So it's not intentionally they don't want to come to the treatment, but what if the treatment have been uh, denied, like the caregiver is not allowing the geriatric individual to go out of the home to get their medication, so this that their treatment will be delayed, right? So any histories which is having any discrepancy, where any contradictions between when we are interviewing the caregiver and also the geriatric individual, when there are any contradictions, then you can suspect from that. And also, if you suspect, you can go for the laboratory findings. Maybe the lab finding also, the laboratory values also can sometimes can be the evidence for you to proceed further. Okay, so this why? Because we need to know about the elder abuse is being pharmacist as a first point of contact for any geriatric care or for any care, like we have to identify this so that we provide a better livelihood for the geriatric individual, right? So in this aspect, like I have conducted another study which we assessed about the knowledge, attitude, and perception on the elder abuse among the healthcare professionals and also among the healthcare students. Our study findings, like this is not among the geriatric individuals, this is among the community pharmacists and also the students who are taking the healthcare courses, where out of the community pharmacists, where 91 healthcare students and also the 60 healthcare professionals have been included for the study, and they have been the participants were found to possess a basic information but not the adequate one, right? So they need to know why it is happening and how to identify, because the difference is why, if you ask like why the healthcare students is having more knowledge, is our curriculum we are having the topics on the elder abuse. So the students who have been taken that course, who have been informed about the elder abuse, they are aware about this one. Where the healthcare professionals, where they are practicing outside, like those who have not undergone our curriculum, but they have been from the other universities, like they are not aware about the geriatric elder abuse or the geriatric care. So they have been unaware about this one, so they are not really know like what to do. Also later when we have found any further, when we have investigated further on the study participants, what we came to know is like they want the this kind of informations to be included in the curriculum of the pharmacy, and especially to be included in the geriatric pharmacy, right? As I believe like this the whoever is the participant today, maybe I think most of the participants are taking the geriatric pharmacy, sorry, the clinical pharmacy courses, right? So clinical pharmacy are the pharmacy practice courses, right? So here, geriatric care needs a special attention. You cannot do simply just like that. And our curriculum, now only we are being more aware about the pharmacy practice curriculum and also like geriatric pharmacy curriculum. Also, maybe we can advocate to include geriatric pharmacy related courses and also geriatric pharmacy related subjects or even the topics over there, right? What I can remember, like when I was teaching in teaching back in India, like with the syllabus, what we have been provided for geriatric and pediatric, like there was only one lecture over, like I think somewhere in clinical pharmacy for PharmD, geriatric pharmacy and the pediatric geriatric pharmacy and pediatric pharmacy, like it is only one lecture hour, right? What we can discuss on that, but there are many things, right? Physiological changes, socio-economics, and also like the other factors which will be playing a role, right? Everything will be taking care of this. If you ask like how this elder abuse is going to impact the drug therapy is, if they are not having an accessibility to perform their activities normally, right? So when they are being abused, their condition is not going to be normal, right? So which will be leading them to the depression, and also like which will be leading them to go with any decisions for ending their life, and also like to stop taking any medications or to stop taking any of the advices on the therapy, right? So this is really important. And recently our another study have been published, so which uh, was conducted among the students, where that also have been providing a good knowledge about this one, right? So this study, this article have compared between the students and the healthcare persons. And in addition to this conditions, the assessment methods that you can do for the geriatric. So if I have left out anything, if you have that question, definitely, I never discussed about the treatment. I never discussed about the medications. Okay. So about the medications, there is one particular group of medications that we need to really take care of is potentially inappropriate medications, shortly known as PIMS. Okay. So this PIMS is playing a major role in deciding on the patient outcome among the geriatric individuals. Okay. So if this is the title or the topic that I'm going to discuss, the point what I'm going to discuss is just tip of the iceberg, right? So if you look into this potentially inappropriate medications, it is a lot. It is a lot to be known, like what are the different classes of medications which needs which needs to be scrutinized for prescribing to a geriatric, right? So any medications which is okay for an adult, it cannot be applied or it cannot be administered to a geriatric individual. So even though they don't have developed any contraindications, they don't have any allergies, but still certain medications are being categorized as potentially inappropriate medications, right? So you can know about the American Society of American Geriatric Society, Beers criteria, right? AGS Beers criteria, shortly known as, right? So they have listed out the list of medications which is potentially inappropriate. So where every one of us, the pharmacist and everyone who are involved with the geriatric care should be aware about, right? So our study finding, we have conducted two studies, like on assessing on the knowledge, attitude, and perception about the potentially inappropriate medications, where this was published, I think somewhere in 20 a few years back. Like this was conducted among the community pharmacists in this state, Kedah. Majority of the respondents have agreed to the incorporation of the geriatric pharmacotherapy education as a core subject because they lacked the information, right? So one of the question, like while we assessing our questionnaire for assessing the knowledge, attitude, and the perception, we have found like majority of the respondent were uncertain about whether the omeprazole is the most commonly Beer's medication prescribed or not, right? So it have to be avoided, but they have been unaware about this one, right? So later they have requested or they have given their comment on like to incorporate on the geriatric curriculum for every way. But our curriculum we have, and also like we do take care of the geriatric pharmacotherapy as well. Where this is the recently published article about the KAP, about the potentially inappropriate medications among healthcare students. Our students have demonstrated an acceptable knowledge, awareness, and perception, right? Here, I'm not saying like exceptional knowledge, attitude, and perception, but only the acceptable level. Why? Because it's like this study, it's not including only a particular year, those who have undergone the geriatric pharmacy curriculum. No, it includes all the years, right? So it includes like the students who have taken the course and who have not taken the course, right? So the geriatric pharmacy is provided in year 4, where the year 3 and before the year 1 to year 3, they have not been aware about this, but the students who have been taken or educated about this geriatric pharmacotherapy, they were being able to have an acceptable knowledge on the in regarding the potentially inappropriate medications, right, which is equally important. But trust me, guys, like the potentially inappropriate medications and also like the AGS criteria, it is a lot. It is a lot to be discussed. Like 1 hour will not be sufficient. So that's why I'm just giving the tip of the iceberg only. Okay, so this may be the another challenge that we will be facing while communicating with the geriatric individual, right? So if the geriatric individual having any visual problem, the auditory enhancements, like they have the hearing impairments, and also like if due to the growth of the artificial intelligence, also like how it can be integrated also. But we need to be more particular, we need to be more appropriate to that geriatric individual. We cannot simply consider anyone by looking into their appearance, and also like we cannot start providing our treatment just like that, or start providing our advice or our care to the geriatric individuals. It really needs a focused approach for providing a treatment for any geriatric individual, right? So with that, as a pharmacist, like when you are coming across any geriatric individual, I think those who have attended this session, I believe like hereafter, if you are in patient care, like when you come across any geriatric individual, I believe you can be aware about like what are the things that you need to take care, right? So simply considering like they looks normal, they looks healthy, like you can easily identify, and also like by implementing certain screening methods, which is very easy. Like it will not take hardly more than 1 or 2. It will take only 1 or 2 minutes hardly. So it is very easy to implement, right? So that by doing this, we identify their difficulties. So we address that so that we achieve the pharmaceutical care outcome in a very better way, right? So by this, uh, these are all the references that I have used for my presentation today, and also like all the articles what I have displayed. It was the research output of my study group. Like I have conducted this study, and also like my study group, we have conducted this study, and it have been published in the repeated articles. Maybe you can. It is available in the profiles also, my profile, and also it is available elsewhere. So in the valid platforms, it is available. So these are all the references that I have used for my presentation. And uh, thanks for your time for listening. And I think if any queries, I will be happy to address those queries. Thank you.
Thank you, sir. So before closing the session, so I have a few questions the audience.
Yes, please, sir.
So one is from, are there any new technological support for geriatric assessments?
Sir, there are many means like there are technological assessments or technological supports are available, but what we can do is we cannot involve technology or the artificial intelligence directly to deal with the geriatric population, because for dealing with the geriatric individuals, we need a humanly touch. Definitely for humanly touch. They are already depressed, and by that time, like we ask them to go with like for even for assessing or for collecting the information, we go with the technology driven one. They may be not so compliant on that. They may not be liking that one, right? If you look into the geriatric individual also, they like more to interact. they like to interact more with the other individuals because they have limited of not facility. I don't say it as a facility, like limited ability to interact at home. Those who are living alone, they don't have any chance to interact much. So here we can include, there are technological supports are available, like even we can integrate the artificial intelligence also in providing the geriatric care. But it needs a humanly touch. Especially we can identify what is the problem, and based on that we can integrate the technology. For example, if drug taking behavior is the problem, like if they forgot, like due to the dementia, if the geriatric individual is forgetting to take about the drugs, maybe we can use the simple alarms or even the reminders through the apps or mobile phone apps, or even the alarms we can set, and we can incorporate it in for them to remind them to take the medications. Or even there are specified or dedicated mobile applications also available, which can be used, like after they take the medications they need to enter it. So which means like we involve the technology also. But similarly and likewise, we cannot completely use the technology for providing a geriatric care, because the geriatric individuals, they require a humanly touch for sure, sir.
So one more question is, what could be the research gaps in geriatric assessments?
Sir, you mean to ask in India or all over the world?
Particularly maybe in India.
Maybe I answer both, like India and outside India. So the research gap, commonly what we will be having is, we need to be patient. We need uh, some what to say, like some permissions, like geriatric population also will be coming under the vulnerable population. We cannot directly go on intervening on their drug taking behavior, because it may alter their outcome also. Where by doing the research outside, there are many opportunities for conducting a geriatric research. Like there is more accessibility, and for India, what I would say is like maybe the lack of information or lack of awareness among the pharmacist ourselves. Like we focus mainly on the pharmacy practice, but we don't, even the pediatric pharmacy, like they may know, like they have a separate set of instructions and separate set of information available for how to deal with the pediatric population, right? But for geriatric means like that, definitely we our setting in India, like we don't have much opportunities or much resources available to do the research. But we have a very good opportunity to collect the data on the geriatric population, because like whatever we do in India, like it can be a very strong evidence for uh, treatment treatment provision for geriatric individuals. So that would be one of the research gap. And also like another gap, what I would say is like uh, the what to say, the relation between the physician and also the pharmacist who are being involved with, right? So far, whatever the assessment methods that I have informed, all those assessment methods, it is just as a preliminary test we can do, and it can be done individually. Even as a community pharmacy setting we can do, but later once we diagnose this, we need to refer them back to the physician, and especially to geriatrician, right? So if you look into the number of geriatricians or the physicians who are being treating the geriatric population, means like there are, I don't think like there are many geriatricians are available in our country also. Very, very limited number of geriatricians, right? So even if you take in the Malaysian scenario also, the number of geriatricians is very little, but they are being involved in geriatric care. But our maybe in India, like maybe I may be wrong also, I'm not sure. But as per my search so far, like the geriatrician, the only the geriatric specialist are very, very little, very limited in number. So which means like the physicians who will be providing the treatment to the geriatric individual, they need to identify first whether all these parameters, like the potentially inappropriate medications, without considering that AGS Beers criteria. So we just provide the medications, means like because it is acceptable for the adult, but it is not acceptable for the for the geriatric population. Maybe if unawareness, it is a problem, right? So we have a huge scope for conducting a research, but while we conducting a research in the geriatric pharmacy or geriatric population in India, I think the physician accessibility also may be one of the gap that we will be facing on, right? So we need to what I can see for as of now.
Yeah, thank you, sir. So you've been talking about different geriatric assessments like the mini cog and cognitive or mobility issues.
Yes, sir.
So for students' point of view, could you suggest one or two references for geriatric pharmacotherapy they want
So
to learn?
yeah, sure, sir. For the students' point of view, like if they want to know about the geriatric pharmacy curriculum, like to know about in short, like they can refer to this first reference, like what I have included, the geriatric pharmacy curriculum. I think it should be available online. This is from the American Society of the Consultant Pharmacists, where they have given the geriatric pharmacy curriculum, and this is about they have included about the physiological changes. They have included about the socioeconomics, which will be playing a role in the geriatric, and those things you can find from there. And in addition to this one, when you are looking into the drug therapy point of view or drug therapy aspect to be incorporated for the geriatric patients, means like I would strictly recommend to go with the AGS Beers criteria, which is known as the American Geriatric Society's Beers criteria, BEERS criteria. So that criteria will give you the complete list of medications which cannot be uh, prescribed prescribed for a geriatric individual, right? So those medications are being categorized as a potentially inappropriate medication. So that will definitely will be a source for a resource, wonderful resource for the for the pharmacists, those who want to take part, or those who want to what to say, like those who want to involve in the geriatric care, like just to know about the geriatric care. And further, if maybe I would like to take this opportunity also, like maybe if anyone interested in the geriatric specialized research, maybe I can help you. Maybe I can help you in that aspect also. So maybe we can decide on do. And also, if any queries also, I would be happy to answer them also. So,
Thank
but
you, sir.
those two resources are very informative, and it will be more appropriate for initially to know about the geriatric pharmacy.
Thank you, sir.
Okay.
So today's topic being comprehensive geriatric assessment. So you have been navigating the audiences through why geriatric particular assessment is unique and needs special care. So key screening areas you have been implicating about clinical implications, particularly of impairments and different screening tools for cognition, mobility, etc. And also evidences from different literature from your publications and others. So thank you so much, sir. So this have been very informative. And I think audiences have been benefited, particularly about this specialized area of geriatrics. Thank you so much, sir.
Thank you so much, sir. And I once again thank everyone, and also special thanks to Anil sir, to you, and also to the management of the Vishnu College of Pharmacy for giving me the opportunity. And I would like to thank our management, the AIMS University, for providing us the resources, and also like all the facilities for the research, and also for going for the publications, and as well as for going for the talk also, right? For permitting me to share my knowledge with this one. I thank everyone, sir. Hope this session was informative. So if any further assistance, maybe I would be glad to help. Thank you.